Good morning, friends. Welcome to the Indian Society Electrocardiology webinar. And it is my proud privilege as Honorary General Secretary of Indian Society of Cardiology to welcome one and all for this IAC webinar. Friends, as all of you aware, IAC, that is Indian Society of Electrocardiology, has been very actively planning this webinar even in this COVID time also. And all of you have witnessed that. Now, we have obviously come out with the third edition. You must have seen the web series one after the other. The second season, third season comes, and this is the in our advanced certificate course in electrocardiology in collaboration with Zydus. We have come out with this season 3, which is Common Cardiology Care for Clinicians, popularly known as C4 modules. And the best part is this time we have got MMC accreditation for this point. So all this part, that is each and every Sunday, which we are going to have it in November, which is going to be have a 1 credit hours for Maharashtra Medical Council. So it's a 1 MMC credit hours. I'm sure all of you have registered the details about all your mobile number, email ID, your medical council registration number, and also your state council with which you are registered. So that would be a prerequisite, and you will be receiving the credit points for this module. And I would be happy to share we have the observer from Maharashtra Medical Council is Dr. Arvind Gongane, who also happens to be the faculty for today also. So friends, we are going to have on 4 Sundays. We started on 1st November. Today is the 2nd. Next Sunday, which happens to be a new year, so there will be a holiday, and 22nd and 29th, we will be having 2 more modules with us. So today's the second module, which is we are going to have is diagnostic modalities in cardiology, which is a very important aspect for each and every clinicians, which we know. And to take this session forward, I invite the moderator for today, Dr. Ramesh Dargad, a senior physician, and he is the honorary physician and cardiologist at Lilavati Hospital, Hiranandani Hospital, Seven Hills Hospital. He has been the treasurer of Cardiological Society of India, Mumbai branch. He is the member of Executive Committee of Hypertension Society of India. He is the vice president of IAC, that is Indian Society of Electrocardiology. He has also been a referee for the JAPI and the Indian Heart Journal. He has been part of the various trials and the registry like STAR Registry, Age Study. He has various publications to his credit and very actively involved in academics. So with these words, I welcome Dr. Ramesh Dargad sir to start the proceedings for it. So we are going to have 3 speakers today, and followed by there will be a panel discussion. So I welcome Dr. Dargad sir. Over to you, Dr. Dargad sir.
Thank you, Ketan, for giving this opportunity. I'm thankful to Dr. Samir Mushala for this enthusiastic support for this ISC activity, which has been very welcomed by all the people. I think today we have taken 3 common important topics for the physician's point, cardiology point of view, that ambulatory BP, Holter, and EP studies. All the 3 are important models for us actually as a physician, and I think will be very helpful to all the audience actually. So our start with the first speaker is Dr. Arvind Gongane, which is known to all of us. He's been quite active in this Goregaon and Malad Association, been past president, also now very active in IMA, API, and RST, and also now Indian Society of Electrophysiology. He's given a number of lectures, written books on the ECG, and he's going to talk to us on the importance of the ambulatory BP. Though ambulatory BP is very important because of its cumbersome nature, I think not as utilized. We can make out a lot of white coat or the mask hypertension, which actually, and I think ideally many of the younger patients at least should be subjected for ambulatory once, at least before we start their treatment. But I think still poorly underutilized because of whatever reason. I think Arvind will be taking over so this ambulatory BP part actually, which is very common thing. I think now home monitoring has become quite common with many of the electronic equipments available to us. But I think ambulatory BP for the night dippers and all that is very, very important for clinical and making a decision for starting the treatment. And even the placing the dosage of the treatment, whether you should give morning, idle, all that will be very, very important actually. So over to Arvind for your this first talk on the ambulatory BP, and this will be followed by the two talks. Thank you.
Thank you very much. Thank you very much, Dr. Dadgad. Thank you, Dr. Ketan, for giving me an opportunity. It's very nice to, in fact, see all the modules that you are creating. It's really worth for everybody in these days that we don't have CME's actuals as before. So coming to blood pressure monitoring, as important blood pressure is, everybody knows the immediate next step to that is ambulatory blood pressure monitoring. I'll just highlight the need of ambulatory blood pressure monitoring and the inferences that we get through that. Hypertension in India, you know, is the overall prevalence is nearly 29.8. It's more in urban. The awareness has increased over a period. The treatment is received only by 37% in urban. Still, we are lacking too much in this. And the control achieved is just 20%. So the reason of stressing about blood pressure and the treatment later on is because we are not aware, we are not finding out cases, we are not treating them properly. All the limitations lead to complications, and patients will have to suffer with that. Benefit of BP control in a nutshell is 10 millimeter of mercury lowering of systolic blood pressure is associated with 50 to 60% lowering of stroke death, 40 to 50% lowering of risk of death by coronary artery disease, and 50% lowering of heart failure. Greater benefit is achieved in older age and at higher initial BP recordings. So it is so important to control blood pressure. That is why is this slide. There are two factors by which the BP recording single is not very effective. One is called BP reactivity. That there are some reasons why the BP can change or have different parameters. Is age, advancing age, male sex, circadian variation. Everyone knows that the BP changes over day and night. Environmental stressors and emotions. Corona itself has caused enough of stress to give variation in blood pressure. Individuals with increased reactivity are called hot reactors. You can find some of your patients behaving very odd in situations. Prediction of future hypertension and cardiovascular risk accordingly can be monitored by serial assessment of blood pressure. BP can vary by heart rate, BP can vary by temperatures, with diabetes, with smoking, with elderly age, vascular disease, and non-responders to treatment. There can be variation of blood pressure. Factors affecting measuring of BP. This is a different zone. Setting in office or at work, in ambulatory setting and home, there can be variable blood pressure recordings. By time, day, night, morning, evening, postprandial, there can be some little difference everywhere. Observer, if a doctor checks, an unknown doctor checks, or a nurse checks, or a technician or relative checks, or the patient checks it by himself, there can be variation. Devices used, we can use mercury, aneroid, hybrid, or oscillometric. There can be difference in the two if taken simultaneously. Posture, basal, we take a sitting blood pressure monitoring. Then lying down can be different, standing can be different. With exercise, BP will be more. Readings, first reading of blood pressure can be different. First day reading can be different. First visit to a doctor can be different. And several readings can show variation as it is. Calculation, somebody has calculated average of 3 BP readings will be more suitable and appreciable. There will be variability, reactivity, and whether maximum blood pressure to be taken or minimum to be taken is a point of discussion. Ambulatory blood pressure monitoring involves measuring of blood pressure over every 20 or 30 minutes as you set in over a 24 hours period while the patients undergo normal daily activities and even sleep. Ambulatory BP monitors use cuff oscillometry. You can see the cuff is here, the same with a machine, and different sizes of cuff are there, and it is attached to the patient for the whole day and night as well. It monitors it with cuff oscillometry, and it defines the maximal oscillations as mean arterial BP, and can then uses an algorithm to calculate systolic and diastolic BP. So this is a different technology to give you more specific readings. Interpretation, the report comes something like this, and it gives a unique data provided. It is 24 hours average BP daytime, that is called awake blood pressure. In the night time, it is called asleep blood pressure. Then systolic blood pressure load, diastolic blood pressure load, and nocturnal dipping of blood pressure. These are the variables that you get in the report of ambulatory blood pressure monitor. It is the values above normal or and below threshold for hypertension are considered high normal. Nighttime average systolic and diastolic BP should be at least 10% lower than the daytime average, which is a normal situation in normotensive people also. Blood pressure load, it is defined as percentage of time that BP readings exceed hypertension threshold during 24 hours. So there will be a graph plotted. I'll show you that. And if suppose normally less than 20% times the BP should exceed the expected range. If not, that is to be taken as positive. Now, this is the most important slide of doing all this talk is, see, on one side you have BP taken in the clinic. On other side, you have an ambulatory mean 24 hours blood pressure. So if suppose both the readings are normal, clinic reading and ambulatory reading, the person is truly normotensive, right? Now, if suppose the BP is more only in the clinic and not in ambulatory blood pressure monitoring, it is called white coat hypertension. It can happen that the patient get excited with the feeling of the doctor, feeling of the hospital atmosphere. Only that time the BP is very high, and if ambulatory done, the BP is low. So once the reading is taken on ABPM, the reading is low. If suppose the other way around, if suppose clinic BP is normal, but ambulatory BP is high, this is called masked hypertension. So it is masked in the clinic setup, but it is actually prevalent in the ambulatory setup. So this is third situation that we can come across. And the last one is both the times the BP is high. In the clinic as well and in ABPM also. That is called sustained hypertension. So it is confirmed that the patient is hypertensive. In normotension and sustained hypertension, we know what to do because it is either this side or that side. The other two situations are to be taken care of. We have to know what is to be done with white coat hypertension, and we have to know what is to be done with masked hypertension. White coat hypertension, when the clinic BP of 140/90 or higher, at least 3 occasions with at least 2 measurements or less of less than 140/90 in non-clinic sitting. So in non-clinic sitting, the readings are low. In clinic settings, it is high reading. It can be mainly because of anxiety of the surrounding or the person taking or the time taken. And BP taken by the nurse may be minimal. It may minimize the white coat hypertension. This is a study in which when the nurse is taken, the reading can come slow. So all such factors you have to remember and negate so that you know the actual situation. Prevalence of white coat hypertension, here it is written 10 to 20%. You may find it to be a little more also. More with apparently resistant hypertension. If suppose the BP is not getting controlled by the medication, then white coat hypertension will be still more because the patient knows going to a doctor that my reading is going to come more. He'll be more excited and the BP will shoot up again. The CV risk with white coat hypertension may be slightly higher compared to a normotensive patient. Okay, it is higher than a normotensive patient, but very much below the risk of masked and sustained hypertension. So by risking normotensive patient number 1, second will be white coat hypertension, third will be masked hypertension, and then sustained hypertension. That is the risk, CV risk of hypertensive patients category. Need for monitoring for the development of worsening hypertension to end organ damage is very much there. Once you diagnose somebody white coat hypertension, you have to monitor them carefully and even treat when needed. Masked hypertension, on the other hand, is normal clinic BP and high ambulatory BP. It is reverse of white coat hypertension. The prevalence is here 10 to 40%, more here. Masked hypertension has been associated with increased long-term risk of sustained hypertension and cardiovascular morbidity. So this is more riskier. In the clinic, you detect it to be normal, let the patient go without treatment, and he doesn't know, you don't know that the patient really has blood pressure. So doing ABPM in such patients, very, very important. You can detect that and then treat accordingly. The graph comes something like this, in which everything is mentioned, and every time a reading is taken, every 20 or 30 minutes the graph goes, and normally, usually there is a dip in the night time. So when the patient is sleeping, both the systolic and diastolic BP are supposed to be lower than the daytime BP, at least 10 to 20%. Nocturnal BP, I said, decreases by 10 to 20% at night. It is called dipping. Now, this dipping can be of different types. Normally the dipping, I said, is 10 to 20%. There can be non-dippers. There can be patients in which the BP is not dipping. It is staying same or very minimal of dipping. This is non-dippers. Or there can be extreme dipping. There can be very big reduction of blood pressure there, or there can be reverse dipping sometimes, not very many cases, but they are called risers. They all will be diagnosed only on doing ABPM. Sleep time high BP is been said to be associated with new onset type 2 diabetes mellitus. This is interesting. There was only one paper. I'm just giving you the finding of the paper. Nocturnal blood pressure and non-dippers. Nocturnal blood pressure is approximately 15% lower than daytime values average in both normotensive as well as hypertensive patients. So in both, this phenomena will be seen when you do ABPM. Failure of BP to fall at least 10% is called non-dipping. Causes of non-dipping are unknown. You really don't know exactly what it is, but some intrinsic renal defects may contribute. There are papers to suggest that. Melatonin also is blamed to have a role in this. Non-dipping, why it is important? Because it is associated with left ventricular hypertrophy, heart failure, and other CV complications. Extreme dipping more than 20% and a large morning surge is also potentially deleterious. Microalbuminuria and progression of nephropathy in diabetes is seen with non-dippers. Decline of GFR, end-stage renal disease, and death with CKD, more so in non-dippers. Sleep apnea will always have a non-dipping tendency. So these are all the factors related to non-dipping. So knowing about non-dipping by ABPM is very essential. Prediction of cardiovascular events, both daytime and nighttime BP predicts CV events, but nighttime blood pressure predicts total CV and non-CV mortality, wherein daytime blood pressure only predicts non-CV mortality. By that, I stress doing ABPM for nighttime blood pressure prediction is very important to know the mortality risk little better than doing it only in the daytime. Indications now, so collectively for ABPM are suspected white coat hypertension, suspected masked hypertension, suspected episodic and labile hypertension, resistant hypertension, hypotensive symptoms on hypertension medication. So medication is going on, still patient has symptoms, do ABPM. Autonomic dysfunction, non-dippers or nocturnal hypertension, pregnancy-induced hypertension, high risk groups with hypertension. So in all of this, doing ABPM will add to your clinical acumen to treat them properly and effectively. Just now we were discussing about home BP monitoring. Nowadays, many people have got machine in the house and they do it. So this is a nice comparison between what ABPM does and what home BP monitoring does. Clinical, we will just leave it like that. Just compare these two. ABPM will have supervision. In home BP, may patient do it alone. There will be no supervision. He will do it by himself. It can be ambulatory. The only difference will be that ambulatory BP will be very important for the nighttime recording. So that will replace home BP monitoring in that fashion. BP variability of 24 hours visit to visit will be known here. Here it will be only day to day. So nocturnal BP recordings missing here. Prediction of outcome is best here because nighttime hypertension is very crucial. Here it is superior to clinic BP measurement, but it is not giving you the night readings at all. Guidance to drug treatment, most complete. 24 hours control if you want. Doing ABPM will tell you exactly how good is your drug to control the blood pressure all 24 hours. Wherein in home BP monitoring, it is limited because you can be better than doing just single reading, but you don't know about the nighttime thing. Improving compliance may be very helpful here. It is best evidence because patient will be comfortable that he is doing it by himself whenever he wants. Of course, he will be comfortable. So both these type of BP monitoring are important in situations given. Finally, to summarize, hypertension 24 hours average BP, if it is more than 135 by 85. This is a rough figure according to various guidelines that we have of hypertension. Daytime awake average above 140/90, suspicious. Nighttime average above 125/75 would diagnose you hypertension. Then you stage them according to the readings. CV complications correlate more closely with 24 hours or daytime ABPM than with office BP. So there lies the importance of doing ABPM for day as well as night to know the situation for incoming risk factors, prognosticating the management of hypertension that you are giving, and then overall prognosis will depend on how best is the ABPM. Finally, to conclude, ABPM is regarded as the gold standard for prediction of risk related to blood pressure. It predicts clinical outcome better than conventional measurements. ABPM may facilitate achieving good BP control more than otherwise. ABPM can diagnose mask hypertension, white coat hypertension, nocturnal hypertension. Home BP may be an alternative to ABPM if it is costly or it is not available. Thank you so much.
Thank you, Arvind, for finishing in time. I think there will be a lot of questions for you because there will be always a comparison with the home monitoring, which is much better compliance compared to everywhere, but with all the advantage of the not deep dipper. So we'll be having the question at the end. So we'll go to the next topic for the Deepak Padmanabhan from Bangalore, who is going to talk us on the Holter monitoring, the other important thing for the physicians to know about. We do get a lot of reports actually. Deepak comes from Bangalore from the prestigious Jayadeva Institute of Cardiology Science. He has worked actually in the Mayo Clinic Rochester. He has a number of research papers, research device, food frontier technology, Nutrec labs, and turtle technology, and all that. He has patented one catheter designed for the electrofusion for the balloon for the pulmonary artery isolation. Actually, it's still pending actually, but very indigenous, his own design. He's been associated in this award for the Indian Society of Cardiology Gold Medal for the last year, and he's a number of presentation. So I think over to Deepak for the role of the Holter monitoring from the clinical point of view or the physician's point of view, which is again very important tool for the diagnosing of the arrhythmia. Actually, of course, now today at least, Holter is becoming much more easier. I can have 1 day, 72 hours, 7 days, and even up to months together with a loop recorder. Now, at least recently, we got very interesting ambulatory ECG Holter monitoring. Actually, we can just put a patch and it can go on recording, and very good technology, which is much more cumbersome. Thinking about the monitor. So I think it's going to be more popular now, and we'll be able to detect arrhythmia, especially all those cryptogenic stroke and where these actually we need, and the management. So over to Deepak for the ambulatory ECG monitoring actually, Holter monitoring.
Thank you, sir. I hope you can see my screen.
Yes, sir.
Perfect. I thank the organizers, Dr. Mehta, Dr. Durga, Dr. Ghungane, and all my colleagues out here for giving up time on a Sunday to attend this session. This is something that's very close to me because I believe that ambulatory ECG monitoring has in it the ability to unlock key secrets based on a lot of function of the heart, and interpretation of this over a period of time will give us certain better understanding on what is the way the heart works, what is the way the slow changes in homeostasis that occur in the human body, how we can predict them, how we can understand where it starts going all wrong. My objectives for this talk are mainly to give a good sense of what is the history of monitoring, what is the present day, what are the various modalities available to us, how long do we monitor in what kind of disease, how do we manage the volumes of data that will come out of this, and finally, how do we report once we've completed monitoring.
Deepak, excuse, if you can make the full screen, it is just coming as a part of screen. So just
my apologies. You
can have to go for full screen.
I just stop share for a second and come back on. 1 second. Sorry about that. Okay. How is this?
Good. Yes, good, good. That's good.
My apologies once again. So what we are dealing with is, what is this device that we are talking about? It's not a single device. These are all a collection of a varied types of devices in the present world, all of which do one common thing. They keep track of heart rhythm. And over these years that we have used this, what we have understood is the best identification of heart rhythm abnormalities is what Holters have, or ambulatory ECG monitors have benefit for. There are use case scenarios where we think you can use it for ischemia detection. There are use case scenarios where we can detect autonomic imbalances based on Holters. But essentially what these ambulatory ECG monitoring devices do is that they tell you more about the heart rhythm than about any other facet of the ECG. That is their best use case scenario. Most of them have some combination of electrodes and a recording device. The electrodes can be placed on the chest. Newer devices are coming where use of the pulse and the fingers along with a recording electrode on the wrist is good enough to give you an ECG. The duration for which you wear is dependent on the condition that you hope to diagnose. There are variable recording mechanisms which record this data and present it back to you, usually through an interface based on a computer. These can be based on either continuous recording of events, which is common in Holters and Root recorders, or it can be based on events where there is an event that the patient has, and because the patient has an event, you want to know the ECG at that point of time or the rhythm at that point of time, and it records it when the patient instructs or initiates a recording. For symptomatic patients, most definitely event recorders are enough. But for asymptomatic patients, giving somebody an event recorder will not serve the purpose, because the patient will be asymptomatic. You will not be able to diagnose what is the abnormal rhythm that is going on. So the history of these devices, the evolution has been phenomenal. From carrying a huge recording device on your back to having multiple wires placed on your chest, going on to small little electrodes that can be implanted in your body, going on to carrying an ECG in your pocket as you go, and finally going on to the watch, which by itself can record your heart rate and prompt you to record an ECG. These are the various ways in which technology has advanced as far as ambulatory ECG recording is concerned. There are additional form factors in the pipeline in the form of wearable shirts, wearable jackets, which have got embedded or woven electrodes within them. But ultimately, what all of this is trying to do is give you either a single lead ECG or give you multi-lead ECGs for the purposes of recording your rhythm. This leads us to an important challenge. How do we know what technology is good for our patients? How do we know that we figure out the most appropriate recorder for the condition? Some important pointers in that respect is to find out what is the fidelity of recording. Does it record correctly? In the COVID pandemic, one of the most important things that has come across is the use of pulse oximeters. It's not uncommon for us to find patients coming and saying, "Doctor, I checked my pulse oximeter, my pulse rate is 40. They panic and they come to you. They take a good 12 lead ECG, you find out that they have some PVCs. The pulse oximeter has not been able to record the PVC as a beat. and therefore it records a heart rate of 40. That is what I mean by fidelity of recordings. The recorder that you choose needs to be able to record the heart rate properly. That's one important thing. Choice of a wrong recorder will lead to unnecessary panic and more investigations. Secondly, whenever you're trying to do a ambulatory ECG recorder, it has to record the ECG also. This is very critical, especially in today's era, because you have appliances that record heart rates. So a heart rate of 120 does not necessarily mean it is bad. It could be 120 for a variety of reasons. But when it comes into the hand of the common man, all he understands is the heart rate. You do not want to have people wearing stuff that record only heart rate. You want it to record the ECG also. So if you are advising somebody to buy a wearable or an ambulatory ECG monitor into their daily lives, you want to make sure it has some form of ECG recording also. Or if that device does not record ECG by itself, you ask them to buy another device which also records an ECG at home. Otherwise, it's essentially a burden of information on your clinic where people are consistently coming to you telling you that you have high heart rates, and eventually it will overwhelm you. From there, you are then worried about storage of data. If you advise a recorder to somebody, who is going to take control and legal responsibility of that recording? Is it you, or is it the recorder or the person who is doing the recording, the technician, and so on and so forth? So whenever you look at continuous ECG recordings, you have to be able to figure out where the legal responsibility lies, especially in difficult events, especially if you have complete heart blocks that you are expecting, if you have sinus pauses that you are expecting in these patients, or even worse, if you're expecting VTs. So be very careful when you advise these particular modalities. Going on, the common indications for monitoring. What do you want to monitor for? You want to monitor for a diagnostic purpose. Say patient comes to you, I have palpitations. It lasts for 30 seconds. I cannot go to the doctor. By the time I reach the hospital, the recorder is done or my events are okay. Then you want him to undergo an ambulatory ECG monitor. Now, depending on the frequency of his events, the type of ECG monitor will be there. If the patient has one event a week and you order a 24-hour Holter monitor, it is not going to pick it up. That patient perhaps wants a 7-day monitor. If the patient has one episode a month, you want to order a 30-day monitor. And finally, if the episode comes once in 3 months or 6 months, perhaps an implantable loop recorder is what you want. So the frequency of the event is a critical determinant of what recorder you are going to use. Why it is important is because implantable recorders usually give you single leads for rhythm evaluation, whereas non-implantable recorders can have the potential to give you multiple leads. The cost factor is another issue. Similarly, episodes of syncope or dizziness. These spells may not occur every day, every week. They may occur once in a year, or they may occur twice in 6 months. So these are again issues that you need to consider the choice of recorder. One of the common indications for monitoring we come across is this monitoring for atrial fibrillation in a patient who has got cryptogenic stroke or a stroke which has no known cause, and the neurologist thinks it's of an embolic origin. In that situation, if you are looking for rhythm abnormalities, the recording needs to be a long duration recording. It may not happen that that episode of atrial fibrillation, which is presumed to have caused the cryptogenic stroke, is going to happen in the 24-hour recording that you do. It's not uncommon to see that. There is a higher frequency of atrial fibrillation in the peristroke period. But in an NEJM trial which was done to evaluate this, ILRs had maximum benefit in capturing or detecting atrial fibrillation at 1 month post-event. You had nearly a 40% event rate. So if you are monitoring for cryptogenic stroke, the decision needs to be taken whether or not you are going to monitor for a month using an external loop recorder or an implantable loop recorder. Doing it half-heartedly gives only a false sense of security to both us as well as the patient. Does not help in the diagnostic probability. This was another study which was conducted in UK, where patients who had palpitations presenting in the emergency room were given the AliveCore device. Now, as you know, the AliveCore device is a handheld ECG recorder, and they were said, okay, we don't have any abnormal ECG findings now. Why don't you take the AliveCore device and go home? In these patients, it was found that the time to detection of symptomatic rhythm was much lesser when they went home with the AliveCore as compared to standard of care. So this may be one of the ways that you can do it if cost is a factor, availability of devices is a factor. Other indications for monitoring are risk stratification. In patients with hypertrophic cardiomyopathy, the presence of non-sustained VT on a 24 or 48-hour Holter is a minor risk factor for risk stratification for purposes of implantation of an ICD to prevent sudden cardiac arrest. So in those patients, it helps as a part of risk stratification. In a patient with ECG suggestive of PVCs, you want to be able to know the burden of PVCs on a 24-hour time period. You want to know if it is beyond 10%, between 10 to 20%, or beyond 20%. You want to know what is the morphology of those PVCs, whether they look the same, they are different. And finally, you want to know if there is any non-sustained VT that goes on. This helps you risk stratify for the patient as far as the possibility of cardiomyopathy is concerned, developing cardiomyopathy in the future. If the patient already has a cardiomyopathy, it helps give you an idea whether this cardiomyopathy can be secondary to PVCs. And finally, if you've put this patient on a medication, you want to see if the medication has been able to suppress these kind of PVCs. Importantly, Holters or continuous monitors can be used in an in-hospital setting also in patients with VT storm. If the VT storm is an episode of ventricular fibrillation, you want to see if there is a triggering PVC, the 12-lead morphology of that triggering PVC, which initiates the ventricular fibrillation. Remember, if there is a PVC that is triggering the ventricular fibrillation, it can be ablated, and that can be life-saving for that patient over a long period of time. So even in in-hospital patients, a 12-lead continuous monitor may have some benefit in being able to diagnose certain rhythm abnormalities. Most of our monitors that we use at the hospital do not have storage facilities and are usually just 1 lead or 2 lead. This is an important case scenario which can have far-reaching effects on the management of these patients. Sometimes we intervene in patients for ablation, and you want to see if the arrhythmia is back or if the burden of arrhythmia is there. This is a kind of a research slash non-clinical indication to a very large extent in our setup, where post-atrial fibrillation, you want to implant these patients with ILRs or have a 30-day ELR to see what is the burden of atrial fibrillation after the ablation. That has some research indications as well as some prognostic use over a longer period of time, telling us what is the recurrence rates of atrial fibrillation in these patients. Another slightly more controversial indication is the use of continuous monitors for screening purposes in patients who have are at risk for atrial fibrillation. In patients with high CHA2DS2-VAS score, you want to know if screening prospectively for atrial fibrillation will actually capture atrial fibrillation in these patients and perhaps prevent them from having strokes in the future. So that is one of the other indications for monitoring in these patients. The Stanford Apple Heart study, which was conducted in 2019, did show some benefit, but then the numbers are less than 50% in most of these patients. And as you can see, the yield goes up as the age of the patient goes up. Data is still required, and there is not an FDA indication for this at this point in time. So as we mentioned, when you are choosing an external loop recorder or an ambulatory ECG monitor, we need to choose the technology correctly. What is the diagnostic power? What is the risk stratification accuracy? Is it cost effective? Giving Apple Watches to patients at the age of 60 and above, where they don't understand how to use it or may not be very savvy with digital technology, may not be a good idea. What is the local availability and experience to understand and detect and evaluate these technologies is also very important. We discussed symptom frequency and the effect it has on the use of technology to monitor these patients. And finally, we need to figure out what is the overall patient clinical condition, which is the most important factor driving the use of this technology. A brief introduction into the various technologies that go into this. If it's an event monitor that you are giving the patient, it is essentially memory that is retrospective. Patient presses a button, that 1 minute or 2 minutes before that is what is stored then by the device. What is full disclosure? It means the device is continuously collecting data from the patient and storing it somewhere. This storage can either be on the device or this storage can be on the cloud where the data is stored, and every day that you use the technology, the memory is wiped clean. The device can record ECGs either as a single channel ECG or a multi-channel ECG. The multi-channel ECG can be a 3-channel, 6-channel, or 12 channels also. If you are doing anything with respect to ventricular arrhythmias, it is usually preferable to use a multi-channel ECG. You do not want to use a single channel ECG for ventricular events, because although it will tell you that the events are there, further on when you send the patient to an electrophysiologist or a cardiologist for further evaluation, they may have to repeat it to understand where that particular ventricular event is coming from. Obviously, continuous telemetry with the device when ongoing recording is happening is something that is available today. And finally, wearable technology. Wearable technology in the form of vests, watches, event monitors like the Fitbit is important. As I mentioned before, critically, you should have ECG recording on these technology for them to be of optimal use and avoid overburdening of your clinic with panicked patients. We discussed the various types of devices, namely the Holters, the extended loop recorders, the patch monitors, wearables, and finally, long-term implantable loop recorders. What is the yield of these devices? The yield is directly proportional to the indication for which you have put it in. For palpitations, the indication, the yield is very reasonably good. It's anywhere between 50 to 80%, depending on the kind of recorder used. For our purposes, a 3 to 7 day Holter will give you a value of 50 to 70% diagnosis for the palpitation event. This is provided the patient has an event during the wearing of the device. That is an important discussion to be had with the patient before prescribing this device. Similarly, if it's an episode of syncope, most of the times ILR has the best predictive value as compared to the other devices. For cryptogenic stroke or silent AF, values are low across the board, and perhaps it's because it has not been tried in patients with high CHA2DS2-VAS score. What are the yield of devices in terms of the number of patients needed? If you're looking at an ILR and the indication is palpitations, you need to implant 2.8 patients to cause a change in the cardiac management of the patient. For cryptogenic stroke, it is 4.5 patients, and for syncope, the number needed for change in management is just as low as 4.9 patients. So these are good devices, provided you use them for appropriate indications. Again, in structural heart disease patients who have a negative EP study and a normal Holter, these devices do yield significant benefits in being able to diagnose various causes. So if you are using a surface ECG monitor, which is most of what we use in daily practice, skin preparation is critical. There needs to be no hair at the point where we are applying electrodes, and there should not be any dirt or grime at that area. Every time you remove the electrode, you need an alcohol-based solvent to clean the area. This cannot be underemphasized. The importance of this is critical, and it's useful to get great quality recordings. Use of good quality electrodes with wet gel at the electrodes helps in improving the fidelity and the clarity of the recordings, especially if you are looking for atrial arrhythmias. For ventricular arrhythmias, the QRS is good enough. It can be seen well. But for atrial arrhythmias, if there is baseline wander, you will not be able to diagnose the fibrillation or the PACs that are seen. And then that particular recording is useless. Before sending the patient home, it's always advisable to do a baseline check of the recording in a variety of postures and positions. You should ask them to avoid potential sources of electromagnetic interference in their surroundings. And if the patient is symptomatic and there are a variety of symptoms, it is very important that they record these events in a diary to be able to correlate with the rhythm later on. Remember, when you have a lot of arrhythmia recording happening, you will look at a lot of ECG changes that happen. But most of the times, those are only significant in the presence of symptoms. There are certain conditions, and we'll come to that later, which require management even if the patient does not have symptoms. But a lot of things we'll see when you're recording continuously need to have correlation clinically before we should act upon them. The routine lead placement in these patients can either be the Mason-Liker system, which is the routine one, or it can be the modified EASI system where leads are placed on top of the sternum here and then into the mid-clavicular and the mid-axillary line on either side. The EASI system is usually used for mobile recordings when 3 or 6 leads are there. Remember, the EASI system is different in the way the QRS looks. So using that to diagnose the QRS site of the ventricular arrhythmia is slightly different as compared to a routine V1 to V6 kind of system. So how do you report and evaluate a Holter record? This is just an example, and there are many such reports that you'll find depending on the company. But remember, all of them report on the heart rate, the ventricular ectopy, the supraventricular ectopy, events of bradycardia, heart rate variability, and segment analysis. The high yield parts of your Holter report, when it's available this way automatedly, is the heart rate, ectopy, supraventricular ectopy, and bradycardia. The heart rate is critical because it will help you diagnose chronotropic incompetence. How? It is by seeing the heart rate range. Remember, if the patient has remained active, and that remains one of the advice you give your patients, you want them to be active when they are wearing the Holter, and there is a truncation of the maximum heart rate of this patient, then you have a suspicion that perhaps in an elderly patient with fatigue, it could be chronotropic incompetence. This will prompt you to perhaps do an exercise test to diagnose that. Similarly, the minimum heart rate should not be a worry, especially if the timing of the minimum heart rate is at night when the patient is asleep. It's not uncommon to see these low heart rates at night when patients are asleep, when there is high vagal tone. Patients on beta blockers, this is a good way to assess if there is excessive beta blockade versus non-excessive beta blockade. And this gives you a sense of what is the range of the heart rate exertion of that patient. When you come to bradycardia, you want to see if there have been episodes where there have been pauses either in the sinus activity or in the A to V conduction. Evaluation of each of these episodes of pauses is important because that will tell you if it is pathologic or not. Absence of that and allowing the machine to detect that means you are opening yourself to greater problems and possible misinterpretation. Ventricular ectopy and supraventricular ectopy need to be seen by eyes to confirm that they are what they are. And a lot of times you will get interchange between these two. So looking at these events individually gives us a sense of what it is. And then based on the ECG available at that time, you can diagnose what kind of rhythm it is. Remember, episodes of non-sustained VT are common, and in the absence of symptoms, nothing needs to be done for them. QT evaluation is a possibility, but clinical relevance in day-to-day practice is not very useful at this point of time. For the heart rate variability, the SDNN is a measure of how much your heart rate varies. And it's a measure of the autonomic function of the body. As a rule of thumb, anything less than 50 means that there is some autonomic abnormality that the patient has. ST segment analysis is an underutilized modality, and it is subject to essentially what the baseline is when you are recording. Not used very commonly, but it has potential to improve detection of ischemia, especially if it correlates at a time when the patient is having activity. These are usually graphical representations of what we are seeing as a distribution of heart rate or ventricular ectopy. And suppose the heart rate is lower, you want to see if it is at the night time or not, or if you want to see the ventricular ectopy is more during the day or during the evening. It's useful to help the cardiologist or the electrophysiologist get a sense of when these are common, and if they have to ablate it, when can they schedule the patient for a procedure. So let's just go through a list of bradycardic events that are physiological and need not be concerned with escalating the care of the patient. If there is sinus bradycardia during rest or sleep, these are physiological. Sinus arrhythmia with pauses less than 2.5 seconds, again physiological. If there is sino-atrial exit block or Wenke block, again physiological. If there is a change in the P wave and the P wave continuously keeps changing without any change significantly in the RR interval at a rate of less than 100 beats per minute, that is what is called an wandering atrial pacemaker, and again doesn't need any evaluation. Brief episodes of junctional escape complexes without any symptoms do not need to be evaluated significantly. And finally, premature ventricular complexes are events that should not require management. Events that need intervention are mainly second-degree AV blocks, third-degree AV blocks, symptomatic sinus pauses greater than 2.5 seconds, and again PVCs with significant burden greater than 10,000 a day with symptoms or in patients with low ejection fraction. Similarly, atrial arrhythmias with long duration greater than 6 minutes or longer require evaluation for purposes of anticoagulation. Pitfalls of any Holter recording: you need to look for drift or artifact. You need to make sure that data is not lost and incorrect time stamping is not present. The reporting of a Holter always requires a clinician-based review of events. It requires correlation between the symptom that the patient has from the patient diary and the rhythm correlation of that patient. You have to evaluate in the setting of the clinical disease that the patient has, and you have to opine on whether this investigation is sufficient or not. Newer technologies bring with them changes in the legalities of management. Who interprets the event and how soon do you have to contact the patient? And newer devices and recordings are present in current day, which will help us figure out whether or not these patients need to come to the hospital for further evaluation. In summary, ambulatory ECG monitoring in current day is a very powerful technology. It needs close clinical correlation and validation of events. We have to choose the optimal duration of observation for the patient, and change in the management of the patient should be carefully decided upon only for events which are non-physiological. Thank you for your patient hearing. My apologies for going over time.
Thank you, Deepak, for taking this high technology. Becoming the ambulatory Holter monitoring is becoming quite high technology now. But a country like India with a large population now, with the aging population also, we'll have to find out some simple solutions. I think like what Apple Watch, or I think the mobile apps that you can screen. I think that Stanford University is actually the study was very important in that way. And I think they screened out, and when the Indian was involved, I think that can be a very helpful, like country like India, in at least detecting elderly people's atrial fibrillation, which is very simple and cost. Because we'll have to think about the cost. Loop recorders in the long time, these recorders are quite good, but the cost is enforced. We'll have a lot of questions during the question time. We are just short of time, so Ajay will get into shorter time. So we have next speakers, Ajay Naik, I think was the past president of the Indian Society of Electrosurgery. Is always involved actively with all the things, also vice president and the Indian Heart Rhythm Society. Presently based in Ahmedabad, though trained from the KEM, is the director of the SIMS hospital. He has a lot of publications and a major international journal. He's always been quite active in the electrophysiology, all activities. Over to Ajay, we will try little high technique, the actually EP studies, and what is the relevance to the actually commonly physicians. So over to you, Ajay, from Ahmedabad.
Thank you, Dr. Dargat. Thank you, Dr. Mehta, for inviting me for this excellent forum, excellent teaching forum. I'll share my slides. I'll over the next 20 minutes, I'll speak about EP study, what a physician should know. EP study is done to diagnose the mechanism of arrhythmia and locate the arrhythmogenic focus or pathway. Whereas ablation is for the treatment, and often it is curative treatment of the arrhythmia by commonly used heat, radiofrequency ablation, or less commonly cold, that is cryoablation, for inactivation of the arrhythmogenic tissue. The history, it all started when His and Purkinje described the special conduction tissue of the heart in the 19th century. And in 69, Ben Sherlag, actually described a reliable, reproducible, simple technique to record from and pace the human His bundle with a catheter electrode. What are these catheter electrodes? You are aware of temporary pacing wires. So these are bipolar electrodes. And when in EP study we use catheters, these are multipolar catheters. So there are multiple bipoles, and we can get one bipolar signal from each bipolar electrode. So it could be quadrupolar, or it could be decapolar, or duodecapolar, that is 20 electrodes in that. And these are used for recording intracardiac electrogram. When we record the cardiac activity from the surface, it's called electrocardiogram. But when we record it inside the heart, it is called electrogram. We need, for the EP study, a specialized EP system. We do it in the cath lab, so there is fluoroscopy. Nowadays, we use 3D mapping. And what is different in EP study is usually you're used to seeing ECGs at 25 millimeters per second ECG speed. But here we are looking at them at 150 and 300 millimeters per second speed. So it is much blown up, it's amplified, and we are looking at the intracardiac electrograms. Actually, this EP study is of a WPW syndrome patient. I have done ablation, and here the delta wave have disappeared in the next beat. The real leap in EP study was again in 69, Turk Durer, and you've often heard of Hein Wellens. They described the programmed electrical stimulation. This was very useful to allow the EPs to investigate the mechanism of different cardiac rhythm disturbances. We could use it for electrical stimulation of the heart delivered in a very specific pattern, and this was helpful in assessing brady and tachyarrhythmias. When we do an EP study, we often have to think, does this study help you in diagnosis of the problem? Is it going to help in prognosis? Can this be helped to offer therapy to the patient? Diagnostic studies nowadays are fairly restricted. In the past, it was mainly done to look at the sinus node disease. You must have heard of sinus node re-entrant time, SNRT or SCCT. Nowadays, mainly it's used for evaluation of syncope if it has not been diagnosed by other methods, evaluation of palpitations, or risk stratifications for ventricular tachycardia, or to assess whether the patient is at risk for sudden cardiac arrest or death. There are ACC/AHA guidelines for which patient should be referred for an EP study. This is just a summary of that. A very practical thing. If there's a symptomatic patient with suspected sinus node dysfunction or suspected His Purkinje block not apparent on ECG, you may have to do a EP study for this patient. Patients with supraventricular tachycardia, resistant to medications or preferring ablation because it is curative and the patient doesn't need to be on medications rest of the life. Patients with wide complex tachycardia, you have to be a little more careful. You have It could be a VT, SVT aberrancy, or you may need to find the etiology. So these patients need to be referred for EP study. Uh, Unexplained syncope, especially in a patient with structural heart disease, LV dysfunction, old MI, what I talked about, for the risk of sudden cardiac arrest or death, they may need to an EP study. Or patients with unexplained palpitations despite all the investigations that Dr. Deepak just talked about. Pre-EP study, the workup, very important history. That will give you clues as to whether you need to do EP study, what you need to do, explain to the patient and relatives, which will help in deciding for the treatment. All available ECGs or any kind of recording of the patient, sinus rhythm, all arrhythmia, electro ECG recording should be analyzed. Echocardiogram is useful because you need to rule out structural heart disease or confirm structural heart disease in any form. And if required, as needed for patients, treadmill test or signal average ECG, Holter, ELR, or a head up tilt test or cardiac MRI may be required. We don't do everything in all patients. It may be needed in some, it may not be needed. What about the contraindications? There are no real contraindications, but when we talk about critical AS or unstable angina, acute MI, acute exacerbation of heart failure, acute metabolic electrolyte disturbances, these are typically scenarios when we would not go for a EP study, but there are scenarios like patient is having a VT storm with acute MI, and there we need to intervene and ablate. And other things like severe HOCM or severe extensive coronary artery disease, uh, infections, etc., where you might rethink or postpone the procedure. There may be some access related problems. Typically, the catheters are introduced from the groins into the heart. If there is valvular stenosis, if there is thrombophlebitis, iliofemoral occlusive disease, groin infection, these are issues which you need to deal with. In some patients, you need a superior limb access, jugular or subclavian as needed. We do the procedures in the cath lab. There has to be a nurse or technician present. In certain patients, you might want anesthetist to be present. Anesthesia are generally required for younger children. We do it under GA or deep sedation in much younger children. In adolescents, we can just go about with sedation. Older patients with local anesthesia, certain diseases or certain morbidities, you might want the patient to be under sedation. Oxygen saturation needs to be monitored. You have to have some form of pressure monitoring. Very important, you need to have a defibrillator that is working in the lab. That has to be checked. And in some cases, we might use remote defibrillation patches. For EP study, we typically want the patients to be off antiarrhythmics for 5 half-lives, but that may often not be possible. Let's look at SVT and VT and the separately. So when dealing with an SVT, ECG gives us a fair idea what kind of tachycardia it is, whether it's a AV node reentry or an accessory pathway mediated tachycardia, or you're suspecting atrial tachycardia, atrial flutter, and where it is coming from the right side, left side, from the septum, AV node region, where the accessory pathway is. So how do we go about the EP study? We introduce under local anesthesia multiple catheters in different chambers of the heart, depending on the suspected diagnosis. So usually we put catheters in the right atrium, right ventricle, in the coronary sinus, in the AV node bundle of His region. Very important. If no His recording, no EP. So no His, no EP. That is a dictum. So these catheters can be introduced from all from the groin or from various from IJV or subclavian, and we get electrical recording from each place. From the RA, you'll get the atrial activity. From the AV node region, you get A, His, and V. From the ventricular catheter, you are getting ventricular activity. So that corresponds to the QRS and to the ECG. The vascular access, typically 3 or 4 punctures are needed, and the catheters introduced in various chambers. We may use femoral, subclavian, jugular accesses. Arterial access may be required for pressure monitoring in certain patients, for left-sided pathways, for retrograde transaortic route, for transeptal puncture, for VT ablations in LV dysfunction patients. So what are we looking at? We are looking at these. This is the ECG running at something like 100 millimeters per second. So only one complex is seen in this strip, and you're looking at the electrograms which are recorded from inside the heart. So this is his recording A, H, and V. This is from the coronary sinus that corresponds to the atrial activity. All electrograms look alike. So what they mean depends on where they are being recorded and their relative timings to each other. So we insert the catheters, measure the intervals, stimulate from various chambers, study the properties of the electrical conduction system, induce arrhythmia, and study the mechanism of SVT by electrical stimulation maneuvers. We can look at whether it's an AVNRT by looking at response to stimuli, whether an accessory pathway exists, prove that it causes the AVRT. In an ectopic atrial tachycardia, localize the focus. In a classic atrial flutter, prove that it is isthmus dependent, the cavo-tricuspid isthmus in the right atrium. If it's other forms of intra-atrial reentrant tachycardia or atypical flutter, where is the circuit? Can it be treated? So these are all things which we look at. The accessory pathways could be located anywhere around the tricuspid valve, or almost 2/3 of the mitral valve, or they could be inside the veins or venous diverticula in the epicardial structures. So these things can be inferred by looking at the various electrical maneuvers and electrical recording. Once a tachycardia starts, analyze how it started, do electrical maneuvers, we terminate it and see how it terminates. Look at the hemodynamic stability during the tachycardia. When do we get excited? Especially in atrial tachycardias or ventricular arrhythmias, when we locate a site that has very early activation. Early activation implies that the tachycardia is rising from that point. And that is the focus we should target. It's like a pond and you cast a stone in it and there are waves which are coming out and you need to find out where the first wave came from. In accessory pathways, we find the spot for early activation of the atrium or ventricle via the accessory pathway or the accessory pathway potential. Before ablation came into the picture in the late 60s, there was surgical division of Kent bundle in the WB syndrome. Then came high voltage DC catheter ablation. There is research into laser, microwave, cryo, ultrasound, but ablation really came into being with radio frequency catheter ablation of SVTs and VT. And now we have 3D mapping techniques for arrhythmias. Cryoablation is used in some patients. And these are other things, surgical radio frequency ablation. Radio ablation is actually using radiation therapy, which is used in cancers for ablation. That has come into picture now. Ultrasound and microwave ablation are much into research. What is RF? It's basically your cautery energy, which is used in surgery. It is adapted to be delivered through the catheter tip. The frequency is between 300 to 1000 kilohertz. It's not painful, does not induce arrhythmia, provides optimal heating. The depth of lesion is around 2 to 4 millimeter. Above 50 degrees, it generally causes an irreversible lesion. So you have catheters, and these are ablation catheter where you can actually introduce the RF current. It produces resistive heating and then produces a lesion which becomes fibrotic and it is electrically inactive. It is not arrhythmogenic. Which arrhythmias are curable? You do a 30 minutes, 45 minutes procedure under local anesthesia. A patient who's suffering from years with arrhythmia on medications requiring to go to the hospital every once in a while. You do this procedure and it is cured. Patient does not have this problem again. So this you can promise the patient in AV node reentrant tachycardia, in WPW syndrome, in these cases more than 98% success. Atrial tachycardia, atrial flutter, a great deal of curative cure promise. In certain idiopathic ventricular tachycardias like RVOT tachycardia or idiopathic LV tachycardia, in diseased hearts, bundle branch reentry, or in post-MI scar-related VT. There are certain arrhythmias which will not be curable, but they are treatable and you can get the problem under control. Atrial fibrillation, or if the patient has multiple morphologies of or circuits of scar-related VT. In certain diseases like ARVD, Brugada, CPVT, you may get things under control. Once you've proved a diagnosis, like an AVNRT, we go ahead, target the slow pathway and ablate it. It's generally more complicated than it sounds. After ablation, we re-stimulate and check if the tachycardia is inducible. So it's like doing an angiography, angioplasty, and angiography again. So EP study, ablate, EP study again. This is a typical AV nodal reentrant tachycardia which is induced. We are looking at these intracardiac signals. Look at the do various maneuvers. Confirm that this is the tachycardia that is responsible for the problem. Look at the electrical signals. I told you all signals look alike. So look at, we have to find the exact location, both fluoroscopically and with electrograms guided, and ablate. If it's an accessory pathway, localize the accessory pathway by mapping. It could be around the mitral or tricuspid annulus. Deliver the energy to ablate it and then reconfirm. So this patient has WPW syndrome. You can see delta waves here. We have induced tachycardia. This is a orthodromic AVRT. Catheters are positioned in various places. And this is the ablation catheter. Ablation catheter has a 4mm tip. The others are 2mm. Look at the electrical signals, and then I'm delivering energy, and boom, the delta wave disappears here. The patient has narrow QRS after that. So the delta is gone during the ablation. The patient is cured of the problem. This is atrial flutter. You can see the sawtooth wave pattern. The classic atrial flutter is around the tricuspid annulus. It's a circuit around it. And we look at the cavo tricuspid isthmus, the inferior vena cava and tricuspid. This is what we need to interrupt, because this is a common pathway where the circuit is going. And this is the right anterior oblique view. So the RA is here. This is the RV. This is a halo catheter around the tricuspid annulus, which you are seeing end on. And I am ablating from the RV aspect of the tricuspid annulus through the isthmus right up to the IVC. So I'm dragging the catheter back and interrupting that isthmus. And this is the intracardiac signals of the flutter. There, it's going at around 376 milliseconds. And during ablation, the flutter terminates and the patient is in sinus rhythm. The electrograms look a little complicated for this. These are complicated arrhythmias. More complex arrhythmias, we use 3D mapping system, which help us in localizing the tachycardia as well. Another example of a tachycardia, this patient had an ectopic atrial tachycardia. We are looking at electrical signals. In cases like this, again, the 3D mapping really helps us in localizing the tachycardia well, and ablating it becomes helpful. So arrhythmias like accessory pathway or AV node reentry, ectopic atrial tachycardias can be tackled fairly predictably. But certain arrhythmias like atrial fibrillation, this becomes a long procedure. We need to tackle it with 3D mapping. Nowadays, we over the last 15-20 years, wide antral pulmonary vein ablation is being done, and that generally controls the problem. There are certain problems where the ablation is not possible. The arrhythmogenic focus or a pathway very close to the AV node or the His bundle region, where it might cause a AV block. So here, a safer way of doing it is by cryoablation. Unfortunately, it's not approved in our country as of now. Epicardial foci or pathways, we need to do an epicardial approach. If there are multiple foci, channel circuits like in chronic AF, curative ablation may not be possible. We looked at SVT. Let's just briefly look at the VT part. Here I am inducing VT. So this patient is in sinus rhythm, and by programmed electrical stimulation, this is electrical stimulation going on. The QRS is wide. This is a drive train of 5 beats and 1 extra stimulus here. And I'm trying to see whether I am able to induce VT. So that was 1 extra stim. These are 2 extra stimuli here. Again, not able to induce. 3 extra stimuli. But at a critical point, when I'm stimulating, suddenly this will initiate the VT. So now the patient has a wide complex tachycardia. It's a monomorphic VT going on. It's a QR pattern in V1 and positive in inferior leads. That also gives us an idea of where it is arising from. I can terminate the arrhythmia just like I started it. So the patient is in VT, and I can stimulate from the EP system, 6-7 stimuli given, and by anti-tachy pacing, I've terminated the arrhythmia here. So diseases like problems like RV outflow tachycardia, LBBB pattern, inferior axis. This is in patients with structurally normal heart. We know where it is coming from. We can ablate it. right bundle, left superior axis, idiopathic LV tachycardia can be very well targeted and ablated. Patient of post-MI, scar VT, ongoing VT, we can localize it and ablate, and the patient is on sinus rhythm after that. Dr. Deepak just talked about idiopathic ventricular fibrillation and importance of identifying the PVCs which trigger this VF. So this patient is getting PVC here. The same morphology of PVC is inducing the VF. So here we cannot ablate the ventricular fibrillation, but we can target this PVC which is initiating the VF, and looking at the signals, we can find it, ablate it, and get the problem under control. Just last couple of slides, what are the complications of ablation? AV block, 1 in a 200 cases, but we are fairly aware of what we are dealing with, and this is quite avoidable. Pericardial effusion, hemopericardium, local infections from the puncture sites, deep vein thrombosis, all this is taken care of when we anticoagulate the patient during the procedure. Vascular problems, local hematoma, thromboembolism, cardiac perforation, death. So minutes, small but definite complications are always in any cardiac invasive procedures you should be aware of, and you should take care of it. Now, when we talk about complications, they always have to be in perspective. EP labs are equipped with the most advanced cardiac support system. So a reasonable claim is that EP labs, particularly those with adequate procedure volume, are the best places for the worst, sometimes even lethal arrhythmic events to occur, because we are all prepared for that. Therefore, EP is a safe procedure, especially in well-established labs. I'll stop there. Thank you very much, and I'll gladly take any questions.
Thank you, Ajay, for covering this important topic of electrophysiology. This is the one branch, I think, where many of the conditions are permanently treated in cardiology, and I think patient doesn't need much of follow-up. In fact, 98% success in AVRT. And I think now more and more, I think people will go for an atrial fibrillation, because now you have considered rhythm is more important than the rate. So I think the importance of ablation even in atrial fibrillation will increase. We'll have a question answer session. Ketan is with me, and I think we start with the first talk actually, first questions to then, and we'll go to second, and then we have only 20 minutes, I think. Ketan, so I think first question to the Arvind actually, were actually about the ambulatory BP he talked. He has to just, questions have come, ambulatory BP versus the home monitoring, advantage and disadvantages. What you think? I think actually the white coat hypertension or the mass hypertension we can make out even with the home monitoring. Only the night dippers we are missing. So it's much more easier for patients. So at least on a few patients, instead of ambulatory BP, can we switch over to the home monitoring, which is now easily available, most of the people have at home? What the advantage and disadvantages? You have talked already in a talk, but I think each patient has some audience has some question on that.
Right, sir, as you rightly said, home monitoring is absolutely needed. So that is a must, which is very easy, and anyone can buy a machine and start doing it for the whole family. That's number one. As long as the things are under control, the BP is under control, there are no other additional risk factors, and things are moving in good way, home monitoring is good enough. It's only when you suspect that the checkup should be also in the night time that ambulatory BP monitoring is important. As I said, night dippers is a special class of people who need to be addressed. In that case, ABPM. Otherwise, home monitoring good.
I think night dippers are very, very important for the cardiovascular risk factor. I think a lot of data of the sleep apnea and this cardiovascular mortality. Non-dippers carry very high mortality and the events actually. So I think the detecting them is very important. But I think ambulatory BP is little cumbersome. Every 20 minutes, the cuff goes and inflates and deflates. Not very comfortable for the patient. So I think some technological new advances needed, but probably it can be simplified, I think. The second one question for you has come. Does every patient who has to be started on antihypertension doesn't need ambulatory BP to be done before they start? At least I think younger patient below 40, if they come, because a lot of things we might miss, does it need to be started doing ambulatory BP before we start an antihypertensive drugs actually?
Yeah, sir, in fact, you rightly said, if available, definitely. It may not be a must, but it would be a booster to what treatment you're going to start and how you will prognosticate the patient.
I think a lot of drugs which claim to be 24 hour are actually really acting. We can always confirm with that. The timing of the antihypertensive also can be planned out in a proper way. Now there's a lot of data coming the night giving the drugs which has been much better. So I think all that can be confirmed, and especially younger patients with a suspicion of white coat. I think all those patients, not of course established patients 65 coming with hypertension and with already reading above 160. So I think I don't need an ambulatory BP, but patient with the borderline, something we see, and relatively young patient who are going to take this treatment for a very long time, I think ambulatory BP will have some role to play definitely, and I think should be used more and more common. The sprint trial cannot be done every patient in our clinic is not possible. So sprint with the ideal way of measuring the BP, 3 readings at a silent room with a 5 minutes interval, taking average of that is most of our clinics not possible. So I think the home monitor to some extent at the ambulatory maybe is possible, ideal for the patients actually. How reliable are the home monitors? I think that's one other question somebody has asked you. That is again, because most of these are electronic apparatus, I think, but I think good devices are quite useful and if properly taken, a can take 2 to 3 readings. I think that's your comment, anything on the reliability of the home BP
See,
apparatus?
sir, nowadays there are good available BP apparatus for home monitoring. They're all good basically. If at all you are using it single-handedly and properly, the model should be seen and then it should be frequently compared with the mercury readings. If suppose you're having some kind of discrepancy, by and large they are good, so no need to worry.
Now we go to Deepak's talk, the second talk, which was on Holter monitoring or the ECG ambulatory monitoring. And you talked about the PVC burden. So can you define what is PVC burden in 24 years or 10,000 or more? Because they are now been associated with the cardiomyopathies and later on, which were thought to be benign actually. So is it really what is the definition of PVC burden we call, and how do you tackle and when do you start a treatment for it actually?
Thank you, sir, for the opportunity. It's a great question. We see PVCs all the time on the ECG, and what we call as PVC burden is the number of PVCs that you look at on a 24-hour monitor, and you assess the probability that those PVCs are going to cause cardiomyopathy in the future, if cardiomyopathy is not existing at that point. If the patient is symptomatic for his PVCs, then you need suppression of those PVCs. And then the burden doesn't really matter. You want them to be suppressed either with medication or with ablation. If the patient is asymptomatic, then you want to see if the patient has a low ejection fraction versus a high ejection fraction. If the patient is asymptomatic with a low ejection fraction and has PVCs on the ECG, you want to know the burden. That is when the question of burden comes. If you have more than 10,000 PVCs in a patient who has a low ejection fraction but is asymptomatic for those PVCs, you tend to think that those PVCs could be contributing to a condition called PVC-induced cardiomyopathy. There are a lot of mechanisms that have been described for it, but none of them have been described conclusively. What is important is sometimes the cessation or stoppage of these PVCs via ablation or via medications can reverse the cardiomyopathy. So it's an important cause of reversible cardiomyopathy in these patients. And finally, you get the question of patient has got PVCs more than 10,000, asymptomatic, and a normal EF. Then you've got to figure out what is the chance that these PVCs will cause cardiomyopathy in the future. This is an area where it's a slightly gray area. As with areas which are gray, there's a lot of literature on those areas. So the latest is a score called ABC-VT score, which is a score that has been recently described in a retrospective cohort, and they validated it in a prospective cohort. So on the basis of that, you can actually determine whether your PVCs that you're recording, if present in a burden greater than 10,000, are they likely to cause VT in the cardiomyopathy in the future? And that then decides or makes you figure out what your modality of management of these is. With a PVC burden of greater than 10,000, even if the ABC-VT score is low, you want them to come back on continuous every 6 monthly to see if the LV is starting to dilate or not. Is the LV ID, internal dimensions, starting to change? In which situation then you need to go and ablate these PVCs or suppress them with medications.
Thank you, Deepak. I think other thing is actually about the duration of this monitoring. You had 24, we have a 3 days, we have a 7 days. We have what should be the ideal? Somebody had a cryptogenic stroke, and I think the event is not known. What is the ideal duration minimum? Because I think the longer you have a cost factor is one important thing for us. So what you think should be a people, a neurologist ask for something, Holter or some syncope person has come. But the minimum duration, you should at least have it to say that is we have ruled out something, not possibly to majority extent. What duration you, very difficult thing. You know, is at least was 1 week's duration, or is the will not pick up, the less chances of getting some atrial fibrillation, all that will be. And the other thing what we talked about is Apple Watch and other thing. I think it's still underutilized actually. I think it's a very great tool actually. One can do in a clinic outside sitting, waiting people also. They just, there are anybody above 65. I think with Hong Kong people did around 10,000 people. And they found that around 5% people had AF, which is just underdiagnosed, and none of them were on anticoagulation. We can actually anticoagulate that population at least at high risk. Maybe in India it may be 4%, 5% what we can. And 10,000 people can be screened in a very short time and without very much of a cost actually. So I think those are the apps which will be, what is the future of those apps? And I think, do you think any more technological advances will come? We have a today single lead only actually, of course, just to know, but is there something further? Jackets and all, they'll be quite expensive. You will have a shirts, designers shirts with judging arrhythmia, jackets you talked about, all those are fancy things. So can you elaborate in the future of this, I think Holter monitoring, how is going to be changed in actually in India, and what way we can help the patient? Just 2 comments on that.
Sir,
Jackets are not still.
I'll address your first question first. What is the duration of monitoring? Honestly, I take the mean of the NEJM study as my mean for managing my patients. If it is cryptogenic stroke, I generally like to keep them for 30 days monitor. I don't like anything less than 30 because that is what showed the maximum incremental benefit on the NEJM study. It was nearly 40%. I don't like to put ILRs on them because most of them, the ILR is the cost of a pacemaker, essentially. So I don't like the ILRs as much. Having said that, what I strictly avoid and I encourage to avoid is the 24-hour monitor immediately after the stroke. In 24 hours, absence of it is not going to prove anything. Presence is good, but absence does not prove it. So AF is something that you need to figure it out that way. Another important thing you brought about the Hong Kong study, sir. What we need to all figure out is the CHADS-VAS score or the CHADS S2 score by itself is a good rule of thumb to tell us which patient you need to monitor prophylactically. Because higher the CHADS score, higher the chance that the patient has atrial fibrillation also. Because these are all lifestyle diseases. They are coexisting, birds of the same feather. They are going to flock together. So having both of them there, right there, that will help you. So if it's a 75-year-old lady with CHADS-VAS score of 3, whose 3-day monitor comes to me with some atrial arrhythmias minimally, and she has had 2 previous strokes which are suggestive of embolic origin, you obviously want to monitor her for a longer period of time. In fact, in a data published in Circulation 2019, in patients with pacemakers in situ who had atrial high rate episodes, it was actually found that if you had a high CHADS S2 score of 5 and above, you could actually start prophylactic anticoagulation without evidence of atrial fibrillation. So what we are trying to reach towards with continuous monitoring is the fact that can you predict and prevent atrial fibrillation as much as possible? It is not for the rhythm control that we are doing these things. It is for the purposes of preventing the stroke, which is the single most responsible for mortality in these patients. And as far as your second one goes, sir,
newer technologies.
The newer technologies are available in 2 forms now. One is the recording of the ECG itself, recording in the form of vests, as I mentioned, but this technology has to yet mature. Today, we are able to use phones, mobile phones, which 10 years ago were extremely costly. So I think over a period of years, this technology also will mature, the costs will come down, you will have alternatives to it. And secondly, we are now able to monitor ECGs from unborn fetuses in the translational level at this point of time. So that technology is again an ECG that is coming up. It's not the old cardiotocograph where you're looking at heartbeats. You're actually looking at a fully formed ECG, P, QRS, and T. So technology is there both in the kind of people that you're trying to monitor, as well as the form factor for that monitoring. And obviously AI to kind of figure out how you can manage this big bulk of data that you are going to be getting once you start monitoring these patients.
I think recently somebody has introduced a sticker on the chest piece and can record up to 7 days. Patient can have his bath normally, can do as much more convenient. I think those technologies are 7 days now. If you can go a little longer, I think that will help the compliance of the patient will improve. Thank you, Deepak. And last two, I think Ajay, there are a few questions. The patient wanted to know what is the difference between radio ablation and cryoablation and advantage and disadvantages. That's what will be the difference?
Yeah, Dr. Darkat, thank you. So there are three different things: radio frequency ablation, cryoablation, and radio ablation. The last one is the latest. So radio frequency ablation, like I explained, it's like your surgical cautery energy, which is while using surgery, you're using a bipolar cautery to do. Here, the cautery energy is utilized to be delivered through the catheter tip only, and that gives resistive heating. So we are heating up the tissue above 50 degrees. It is still below 50 degrees centigrade of tissue temperature. It is still reversible. Beyond that, it becomes irreversible, and beyond 65 degrees, it's irreversible tissue injury which is created. In cryoablation, you are cooling the tissue down. So this is a specialized system. Again, you're introducing cold energy into the, suppose I'm doing a slow pathway ablation for EV node reentry. I'll find the exact spot and turn on the cryo mapping. Why it cools the catheter tip down, just like when you sip ice, it sticks to the tongue. The catheter tips, when it cools down, sticks to the tissue. And when I'm reducing the temperature to about minus 30 degrees, it is still reversible till that point of time, but the conduction may go away. And I'll come to know whether that energy is effective or not. If it is not effective, I'll warm it up again. Or if I'm very close to the AV node causing problem to the conduction system, I can reverse it. However, if I'm at the right spot, I'm not causing any problem to the normal conduction system, I can reduce the temperature to even lower and then make it irreversible. So that is cryoablation. The third thing is radio ablation, which I said it's very latest. It's just been started over the last 2-3 years or so. The patient is in a stereotactic system, and like radiation is given for chemo, for cancers, for ventricular tachycardias or atrial fibrillation, you can map out where you want to deliver the radiation, and radio therapy ablation can be given. It's still early days for that, but it is maybe something for the future.
The second question is that does the scar produced by the RF ablation can cause again arrhythmia? That's
yeah, so that is precisely
what is the actually
yeah, I showed you the picture. The whatever injury is produced, it's fairly it is well circumscribed. It's 2 to 4 millimeters. It's electrically inert. It causes fibrosis, becomes electrically inert, so it is not arrhythmogenic. However, like in atrial fibrillation, where are chronic AF, there are multiple scars, and you are producing linear ablation. If you leave out areas unablated, that can create channels for new circuits to form, and patients may get intraatrial reentrant tachycardias due to that. So the ablation energy or the ablation lesion itself is not arrhythmogenic because it's electrically inert, but the way you create those lesions may cause potential channels to form and become potentially arrhythmogenic. But these are very complex issues, and they are dealt with and they are addressed well.
Most of the time, that's what they relate. What is the recurrence of post-RF ablation of the arrhythmia? Is a 98% success, you talk.
Yeah, so
at least
typically, absolutely. So for accessory pathways, AV node reentry, success rate is more than 98%. For atrial flutters, it's close to 95%. For ectopic atrial tachycardias, between 90-95% or so. The recurrence is generally, we talk about 1 in 100 in these accessory pathways and AV node reentry. In the vast majority, generally, it's not an issue.
So that's quite a good suggestion. Now, I think last question about the atrial fibrillation. Now, more and more ablation techniques are coming up, and it is with a better success, I think, what was previously, because we want to achieve the rhythm control in the majority of the patient, because now the data is very clear. So what is the success of the atrial fibrillation and ablation now?
Yeah, the success rate depends on the patient milieu. So if it's a younger patient, otherwise normal heart, the atria are not very dilated. In these patients, we generally talk about a success rate of close to 70 to 80% for the first procedure. If the patient requires a second procedure, the success rate could go to 90% or so. If you're on the other extreme, if you are taking a patient with elderly patient with structural heart disease with dilated atria, and it's not only paroxysmal AF, but patient has persistent AF or long periods of AF, patients on multiple medications, then in these cases, if we need to ablate, then we need to temper our success rates to 50 to 70% for the first procedure, and the patient may require a second or third procedure.
I believe there was one trial where ablation was compared with the pharmacotherapy, and of
Yes.
course, all those antiarrhythmic drugs have a toxicity in a long time. So everybody
True.
will like to be off the thing. So at least definitely ablation should be given an attempt in all the patient if possible. Success rate may be 50 to 70% in the past. Maybe required the procedure can be repeated, but I think it's much better than taking the drugs for a long time, which have even Ambulatory like drug, which have a toxicity, or any drug will have a toxicity. So
Yeah,
I think
Dr. Dargat, just like I said, a lot of arrhythmias are not cured by this, but can be treated and controlled. So
can
AF
reduce the
falls
dosage
amongst
down.
that. You are able to get the things under control, and you can reduce the number of medications. The patient may need to be on anticoagulation anyway, but at least the antiarrhythmics you can manage a little better, and you can give lasting relief to the patient.
Drugs. What about ventricular tachycardia actually?
So with ventricular tachycardia, actually, it is excellent for treating for patients with normal heart. Like I said, the outflow tract tachycardia or ILVT, Purkinje-based tachycardias, it is almost curative in these patients, and success rate is more than 90-95%. With scar-related VTs, especially patients who come with VT storms, so multiple episodes of ventricular tachycardia, patient has an ICD, multiple shocks. In these patients, it is a boon to have ablation. You can take care of the VT storm, and the patient, the problem can be brought under control. In other patients also, post-MI, structural heart disease, scar-related VTs who are getting frequent episodes, who need to go to the hospital many times. In these patients, it can give lasting relief to the patient. And the antiarrhythmic burden and etc. can be much reduced.
Ajay, there was one paper with the renal nerve denervation also reduces the ventricular burden. Is there any you have experience? And what is the role of vagal nerve ablation cutting? That's
so a lot of it is published from the West, from UCLA also, and Dr. Narasimhan has also done some work from Hyderabad in patients with ventricular tachycardia.
Ultimately, we are reducing sympathetic overactive.
Yeah, renal denervation is one of the things which may reduce the
ventricular burden,
ventricular tachycardia burden. So it is one of the things which may help contribute. That is not the only thing which can be done to take care of it. So you need to address the problem, and this will be additive to whatever is being done.
And vagal nerve, cutting vagal nerve, or this actually vagectomy.
Okay, so those are again for specific problems. So if it's a long QT syndrome and patient is getting ventricular arrhythmias, or patients with VT storms, where we can do cardiac sympathetic block initially. If it is effective, then cardiac sympathetic denervation surgically, thoracoscopically can be done. And that is also very good for certain patients. But you need to identify the subset.
People who are on a 3-4 drugs and still not control, I think that's the last resource.
Yeah, you need to identify the patient, and it gives excellent therapy for certain
we are actually at Ketan, we are at 12:35 actually as per the time allotted by you.
Yes.
So I think anybody has a concluding remark, Ketan, you can have, or Dr. Deepak, or anybody has anything on the overall, any comments, just 1 2 minute short comment. Ajay had already told. Deepak, you have any comments actually on I think the AP studies actually, because you talk apart from your talk, anything you feel actually we can add, and then I think we'll hand over to Ketan for the ECG quiz, which is going to be there after this actually. So any final comments from the Arvind yourself or Dr. Ketan, who were there actually. Amit Vora is also, I think, joined with us. So Amit has any comments actually, can just give any. I think Deepak, you can put your comment, and I think we can take and then hand over.
Sir, the only thing I have with most of the lifestyle-based arrhythmias is that we should not wait too long and then try and ablate them. You want to ablate them at a point where they will have benefit, rather than taking them in a situation where the LV has already deteriorated to a significant extent, and then you try therapies. The outcomes are not as good
by the time they're done.
So doing it early in the pathophysiology of the disease will always give benefit. And a lot of it also has to deal with the quality of life improvement that these patients have. Coronary artery disease in India is a decade earlier than the West. Essentially, we also have a lot of people in the prime of their lives, providing for their families having arrhythmias. We have to be relatively more aggressive with due caution in being able to manage these arrhythmias and tailor the treatment to the patient. That's my call.
Anything, Dr. Ketan, actually, or Dr. Amit,
Sir, I think no, sir, we will be sorry, but I will have to cut short because the most crucial part is coming up now.
Yes,
So thank you so much, Dr. Dargad. You have conducted the panel discussion so well with all the three speakers, Dr. Arvind Gongane, with Dr. Deepak Padmanabhan and Dr. Ajay Naik, who had joined, and the fantastically the things were conducted. Friends, Dr. Dargad, I am sure, has really conducted the panel discussion so well. We are thankful to all of them. And now it is the time for the master thing, and that is the ECG quiz. Today, what we are going to have the ECG recognition pattern. And because our theme for today was diagnostic modalities, and everything what we are discussing today is about diagnostics. And who better than a quiz master can be there for today's session, and that is Dr. Amit Vora. I am sure Dr. Amit Vora does not require any introduction to this crowd and this gathering, because he is not only a national but international figure when we talk about the ECG modalities. He has done his MD internal medicine, DM, DNB cardiology, renowned electrophysiologist, not only in India, across so many countries. I would say that he is the partner in Arrhythmia Associate India. He is the ex-associate professor at Department of Cardiology at KEM Hospital, Mumbai. He has a vast experience in RF ablation and device implantation, has got more than 125 international publications. He has been immediate past president of Indian Heart Rhythm Society, currently vice president of Indian Society of Electrocardiology. He has been a reviewer of various journals, including JAPI and Indian Heart Journal, has been a principal investigator and pioneered many studies in AF, like CRAFT, IHRS, AF registry, so on and so forth. And I had the privilege to work with him when he was my registrar, when I was doing as a housemanship in cardiology during those times. So I remember date back to our KEM days. So that was a fantastic experience working with Dr. Amit Vora. I would give few instruction for the delegates. When you are seeing the slides, you will see the questions on the right hand side. When Dr. Amit would give the flash, the questions, it will be seen on your right hand side if you are using the laptop. If you are using the mobile, the questions will be at the bottom end, and you will get, after he finishes the question, he will say your time starts now, and then you will get total of 30 seconds to answer that questions, and then you will see the graph, and Dr. Amit Vora will take the discussion on that. So we want all of you to participate actively in it. Don't worry, your name will not be disclosed. So even if you are wrong, don't worry, come over and participate. It is the total cumulative data which will be shown over here. So it is all over to you, Amit, as a quiz master.
Thank you, Ketan. Thank you very much for the kind and generous introduction. All right, let me start sharing my screen, and I will. I hope my screen is now visible to all of you.
Yes.
Good. So, we are going to go through this session, but I must admit that no investigation should ever be taken in isolation. You should always know the clinical context. Very important to know the clinical context to understand the relevance of that investigation. So ECG is also the same thing. The clinical context remains of utmost importance. Correlation of the ECG with the clinical context is very important and relevant. Having said that, as a matter of being very proficient in ECGs, there is something which we call as, a pattern recognition. A recognition on an ECG or an X-ray, which is kind of a spot diagnosis. You just look at it and you come to a conclusion that this is what is going to be. Of course, you are going to cross-check and verify with the clinical context also. But the theme of this presentation is going to be pattern recognition. So I'm not going to give you much history at all in the beginning. I will just throw up ECGs and I will request you to try and identify what pattern it fits in, because at the back of the memory, if you know these patterns, you will be able to answer them well. So I'm going to show you the first ECG, and this is the first ECG, and this is a 12-lead format: 1, 2, 3, AVR, AVL, AVF, V1 to V6, and this is the rhythm strip, long lead 2. And the question to you is whether this is a supraventricular tachycardia or a ventricular tachycardia, and I would want the timer to be started now. All right.
3, 2, 1.
All right. Thanks for voting. And as you see in this graph, almost 75.
You'll have to change this, Amit. You'll have to change this because we can't see the.
You can't see the graph. Okay. Okay. So I need to share the screen. So are you able to see the graph now? Because
no.
Sir, you have to stop share and select the screen.
I have to stop share. I have stopped share and select.
And select desktop.
Okay. Okay. So we'll have to do this every time.
No.
Are we?
Sir,
yes,
sir,
we can.
Sir,
you can
stop share currently.
Yes, we are seeing it.
You are seeing this. So I think 81% of them have voted for SVT, and a very small minority has voted for ventricular tachycardia. Well, let me go back to the ECG. Are you seeing the ECG now again?
No, sir. Sir.
No. Okay.
Sir.
So we will stop share and go back.
Stop share and sir, select the first option, desktop. You can see there is one desktop is there. Just select this.
Okay. Share screen, and there is a desktop as a first choice. So I will share this so that we don't have to toggle again and again. I get it. Yes. All right. Okay. So this was the ECG, and this ECG is in front of you, and we wanted to ask you about SVT or VT, and obviously, SVT is wrong diagnosis. This is a ventricular tachycardia, and let me tell you what you need to recognize in a ventricular tachycardia in this patient, in this ECG. What we want to see is that what is the QRS width is what we want to look at. Now, many places the QRS width might look narrow, but obviously, the QRS width in lead 2, you can realize that it's definitely 120 millisecond and more. So it is relatively narrower, but it definitely is crossing the 120 boundary. And therefore, you have to think of SVT with aberrancy versus a ventricular tachycardia. And then you look at the bundle branch morphology. It's an RBBB-like morphology, but this RBBB pattern is with a left axis deviation. So RBBB with a left axis deviation, you should think of ventricular tachycardia, especially idiopathic left ventricular tachycardia, the fascicular ventricular tachycardia, the one which arises from the left posterior fascicle in young children. This is one that can be successfully operated, young children and adults also. So if you look at the rhythm strip, you will then be able to identify that why am I saying this is a ventricular tachycardia. If you look at these T waves, on the T wave, you see the change in T wave morphology happening. The change in T wave morphology is a predictor of an AV dissociation. So there is an AV dissociation here, and this is a ventricular tachycardia, and RBBB left axis and happening in a young person with structurally and functionally normal heart. This is an idiopathic VT, left posterior fascicle origin VT. This is the Belhassen VT. Now, the important thing about this VT is that if you give calcium channel blocker, thinking that it's an SVT, it will terminate the tachycardia, and you will label this as an SVT. But this is a VT where calcium channel blockers work. As Ajay mentioned, some of these idiopathic ventricular tachycardias, they behave like an SVT. So AV nodal blocking drugs can terminate the tachycardia, and they can be successfully ablated also. So now remember this pattern. RBBB like left axis deviation pattern could be a fascicular VT in a young person, and the proof would be when you see AV dissociation also. So I'm going to move on the next ECG, and the next ECG shows lead 1 to V6 is arranged one after the other, and this is the pattern. You have sinus rhythm, few white QRS complexes, sinus rhythm, few white QRS complexes. Now you have to tell me that this white QRS complex, obviously it looks like a ventricular tachycardia, no question about it. So this triplet and this 4 beats and this longer run, is this ventricular tachycardia suggestive of a idiopathic left ventricular outflow? So is it coming from the left ventricular outflow tract? Is it coming from the right ventricular outflow tract, both idiopathic? Or is this probably in a patient with non-ischemic cardiomyopathy and frequent runs of VT? Or this is an ischemic heart disease and ischemic scar-related VT? Your time starts now. Let's start the counter. All right, so let's look at the voting pattern, and what do we see? Majority have said it is an idiopathic right ventricular outflow tract tachycardia. There are few people who think that is ischemic heart disease, and there are few people who can think that is a non-ischemic cardiomyopathy. Now, you know, I'm happy that vast majority who have said right ventricular outflow tract tachycardia idiopathic variety is correct. Let's go back to the ECG. And in this ECG, what you need to see is, you have a normal sinus rhythm ECG here also. And look at the QRS morphology and QRS characteristics. In the sinus rhythm ECG, the ECG is completely normal. There is no evidence of a old myocardial infarction by a Q wave. The QRS is not abnormal or scarred to suggest any cardiomyopathic process at all. So the sinus rhythm ECG also should be looked at. It's completely normal. And then we focus on the VT, which now we know it's idiopathic because ECG shows suggests a structurally normal heart. And on this, we look at the bundle branch morphology. That is what helps us to decide what is the origin of the tachycardia. And we see in V1 and V2, there is a QS. Even in V3 QS, R comes up only in V4, V5. So it's an LBBB-like. It's not typical LBBB. It's an LBBB-like origin because it's showing a LBB-like morphology. And if it's an LBB-like morphology, it is originating from the right ventricular outflow tract tachycardia. It will, anything which originates from the opposite ventricle will give a bundle branch morphology pattern of the other ventricle. Because if the activation begins in the right ventricle, it will appear as if the left bundle were blocked. So this is an idiopathic right ventricular outflow tract tachycardia. Ketan, you are there as moderating. If there are any questions or if there are any comments, you can please let me know.
Yeah, sure.
All right. So we'll move on to the third ECG. And this third ECG also is a pattern recognition. This is a little ghastly variety of tachycardia which we are seeing. It again is what we call a wide QRS tachycardia. That is not in doubt. It is the width is pretty broad. It's a broad and wide QRS tachycardia. It shows some amount of irregularity in the RR. And that is where my question to you all is that this ECG, does it look like a monomorphic ventricular tachycardia? Choice A. Choice B, no, it is a polymorphic ventricular tachycardia. Choice C, it is atrial fibrillation with a rapid ventricular rate and underlying is a left bundle branch block. That's why the QRS is wide. And the last choice is atrial fibrillation with WPW or Wolff-Parkinson-White pre-excitation. And your time starts now. All right. So I think in question number question number three, last choice was atrial fibrillation with a WPW pattern, and 40% seem to have given that answer. But a few also think that it may be a atrial fibrillation with left bundle branch block, and some of have given a answer of a polymorphic VT. 25% say polymorphic VT. Very few monomorphic VT. Let's go back to this ECG and understand all the choices that I have given. Now, the terminology of monomorphic and polymorphic. So I'm not talking of the VT, but let's look at the terminology, monomorphic and polymorphic. What is monomorphic? Monomorphic is when beat to beat, the QRS morphology is more or less similar in a given lead. So in this particular lead, say long lead 2 rhythm strip, beat to beat morphology is similar. So you can say that this is a monomorphic tachycardia. Polymorphic tachycardia, in that same lead from beat to beat, there will be a variation in morphology. If there is a beat to beat variation in morphology, you call it a polymorphic ventricular tachycardia. So this is definitely not a polymorphic tachycardia. If at all, you can say it's a monomorphic tachycardia. So now the question is it a VT, is it a left bundle branch block, or it's a WPW pattern? Now, LBBB, you have to realize that whenever you talk of LBBB, it should show a typical left bundle branch block pattern. Now, if you look at lead V1 and V2 suddenly there is a tall R wave, and it doesn't show the typical M pattern at all. In V5, V6, a QS pattern in V1, V2, V3 should be there. So this is not a typical left bundle branch block at all. If it's not a typical left bundle branch block, it can't be an aberrant conduction. So this also is out. Now the question is it a VT or atrial fibrillation? And the fact that you have a RR irregularity, irregularly irregular RR is what is seen, and that is a hallmark of atrial fibrillation. So this is not even a monomorphic VT, and therefore the correct diagnosis is it is an atrial fibrillation, but the wide QRS is because of pre-excitation, WPW pattern. So this pattern recognition is very important because this is what can potentially lead to ventricular fibrillation and sudden death in patients who have a WPW syndrome. So if you see a fast, a broad, and irregular tachycardia, F, B, and I, then it is the diagnosis is AFib with WPW. These need to be electrically cardioverted, restored sinus rhythm, and they should be subjected to radio frequency ablation, which can cure them and prevent sudden death. All right, I'll move to the fourth ECG. And this fourth ECG, I've kept the pattern similarly. So you looked at all these white QRS. Earlier we discussed about this pattern, it being monomorphic, polymorphic. So again, a white QRS tachycardia is seen in this kind of a Holter strip, rhythm strips are there. And the question to you is this only: is this monomorphic? Is this polymorphic? Is this an electrical artifact? Or is this atrial fibrillation? Your time starts now. Can we have the music, please? All right, so let's see what people have voted in this rhythm strip, and vast majority have said it is choice B. Let's look at this. I'm glad the choice B is a polymorphic ventricular tachycardia. So that is the correct answer. So here in this particular lead, what we see is changing morphology. This morphology is different than this, and then again they are different. So there is a changing morphology in that given lead itself, and therefore this is what we call as polymorphic ventricular tachycardia, obviously wide and bizarre. Now, you know, some people have said atrial fibrillation. No, this is irregular, sure. But look at the type of QRS. This bizarre QRS definitely tells us that this is a ventricular tachycardia. And then you should also look at the ECG when in sinus rhythm. And in ECG in sinus rhythm, what you see is PQRS. There is a bundle branch block-like pattern, whatever we can appreciate. M pattern here, S wave here. And what's happening at the end of the strip? At the end of the strip, we can see P wave, a P wave, a no QRS. If you look at the QT interval, the QRS begins here, the T wave continues, the T wave continues here. So long QT, PVC, throwing into a polymorphic ventricular tachycardia, and this is the underlying clue. What is this long QT due to? It is due to a complete AV block, PP. So there is underlying complete AV block, and this is a false sense which tells us that the P and QRS are related. They are not. If you look the P wave previously, it is not conducted with the QRS. And when you see in a long strip, you realize that there is a complete AV block. So complete AV block, escape rhythm, complete AV block often in some patients will be with a longer QT and cause a polymorphic VT. So patients with complete heart block die not only because of bradycardia, but some of them can die with polymorphic ventricular tachycardia also. And therefore a temporary pacing wire may be very essential in some of these patients with complete AV block. Let's move on to the next question, question number 5. And here also, I am already saying, I don't know how well this ECG has come up on your screen, but you have the limb leads, 1 to AVF, and at the initial part, you have this complexes, and then it goes into a polymorphic VT. So the polymorphic VT definitely is there. And now the question is, this polymorphic VT is due to what? So look at the limb lead here and now try to answer, what is this polymorphic VT due to? Is it due to inferior wall MI? Is it due to anterior wall MI? It could be a hypokalemia or pericarditis. Your time starts now. All right, so people have recognized, majority have recognized correctly that this polymorphic VT is because of a inferior wall myocardial infarction. This is because of an inferior wall myocardial infarction. And this is what is seen in the ECG here, that you have lead 2, 3 and AVF. See the way the ST is elevated, gross elevation of ST. This is almost like a box pattern, like a action potential seen. So when you have an ST elevation which is this high, it is a malignant prognosis, malignant outcome. More than 50% of the R wave, if the ST is above that also, it tells you of a severe myocardial necrosis and bad prognosis. So these patients should be taken up in the cath lab immediately and should offer a revascularization. All right, so these were all the examples of polymorphic VT. This is one more situation of a polymorphic VT. So in a Holter strip, you can clearly see torsade the pointus twisting around its baseline, polymorphic ventricular tachycardia. This is what I've blown. Polymorphic VT and then the strip here. And my question to you here is, in this patient, a Holter monitoring was done, and this is the Holter monitoring strip. And this was the previous ECG. The child is known to have syncope, and you have a polymorphic VT, and the Holter shows this. And what does the Holter strip show? Does it show A, long QT, T wave alternance, hypokalemia, or both A and B? And your time starts now. Music, please. Is the music on? I can't hear the music.
Ten, 9, 8, 7, 6, 5, 4, 3, 2, 1.
All right. So this is the question. What does the ECG show? And vast majority have said both it is A and B. Very, very true. So we are talking in terms of a long QT interval and T wave alternance. So identifying both is very important. So yes, you see the QT interval. See where in this case QRS begins and T wave ends just and the next QRS begins. T wave ends very, very late. So rough eyeballing should be that if the QT interval is 50% or more of the RR interval is here, you draw a line, this is a 50%. If it's more than 50%, this is a prolonged QT. So it's a long QT. And what we see is T wave alternance. I think that is what needs to be identified. See the T wave alternance. Here it is inverted, here it is upright, inverted, upright, inverted, upright. So this is in a congenital long QT syndrome. These T wave alternance are known, and these T wave alternance are fluctuant with different times. So if you see the all ECGs, you will not realize at all in this bottom ECG. You won't even realize that there's a long QT here. Here there is no T wave alternance, but you can say that the QT is long. Here there is T wave alternance, but it is seen more prominent probably in one lead only. But again, the direction is very subtle. But here there is gross. So it's a very dynamic thing. Long QT, T wave alternance is very dynamic, and you may often pick it up on a Holter 24-hour monitoring rather than a single ECG. It is a bad prognosis sign. These are the children who can have sudden death because of long QT syndrome. Let's move on to the 7th question. And the 7th question is, again, bizarre looking complexes, very bizarre looking complexes. When you have a bizarre looking complex like this, you need to be very vigilant. I'm not going to give you any story, and you have to answer me whether the ECG is like a polymorphic VT. We talked about it. Whether this ECG shows ventricular fibrillation, whether it is an artifact, or I am not sure what the diagnosis is. Please switch on the timer.
3, 2, 1.
All right, so let's look at where we are. And I am not, there is a division in terms of VF and artifact. And some thought that this could be also a polymorphic VT. And very few people were confused also. So I think, yes, this is a tricky one. And you need to decide whether it's VF or an artifact. And let's look at the ECG now a little more carefully, whether this is VF or this is artifact. So, you know, it's a little odd in a VF situation that you have these complexes in between, which look pretty regular interval and up. So now what is important is, and this is an undulating waveform, this is what we can see. We need to analyze it very closely. And when we're trying to analyze it very closely, what we are going to do is, we are going to mark the point where we see, why is this an odd one? And this also is an odd one. These are also odd ones. So these are all timing itself very well, odd ones, sharp complexes in between these wide QRS complexes. So these actually are the intrinsic complexes, and this wide complex is nothing but an electrical artifact or noise. So it is very important. Again, clinical context here will be very important. If a patient has VF, you would have had a stroke Adams and you will have to cardiovert the patient, defibrillate the patient. Now, in this patient, obviously, he had no symptoms. He was sleeping while he's being monitored. And what is important for you to realize or understand is, see the kind of complex. If this were a fibrillatory wave, then the next QRS can't be so narrow, normal looking. You can have fusion of a normal, narrow QRS and a VF. See how sharp this complex is. So all these are of a similar morphology. So this is clearly an artifact. So I think artifacts is something which you should also think of when you see relatively wide QRS complex. Clinical context here, I think, is the key. However, if you are just shown this ECG, you should run it, time it, and if they time out very well, because if it's a VF polymer, nothing will time out. The QRS won't time out at all. So now we move on to the next ECG, and this next ECG is of a patient who, of course, we want to recognize the pattern. So I'm just showing you the ECGs, and I'm asking you this question: what does this ECG show? Does this ECG show your choice A is sinus node dysfunction? There is a bradycardia, or is it a fine atrial fibrillation and a slow ventricular rate? Choice C is hyperkalemia. No, this is acute coronary ischemia. Your time starts now. All right, so let's see what the answers have been given. And this is the ECG, and what we see is 50% seem to think that is a sinus node dysfunction, and there are a few people who have said hyperkalemia, and nobody for acute coronary syndrome. I think that is very impressive that nobody thought so. And the correct answer, let's look at the correct answer. What the correct answer could be. Is it a sinus node dysfunction or hyperkalemia? That is where the debate seems to be going. And I would actually say that those who have said sinus node dysfunction is not wrong, because you have marked bradycardia, no P waves, junctional escape rhythm, and then the QRS and T wave, and again, two beats together, and then a pause, a sinus pause, would mean that this is sinus node dysfunction. So I think I wouldn't disagree with it, but let's look at it carefully. And what we find is very strange that see this tall peaked T wave in V4, V5, even in V6. In V3 also there is a tall peak T wave. So this tall peak T wave and bradycardia. So I think these two combination should also make you suspect of a hyperkalemia situation. And actually, this patient had a potassium of 7.2 when this ECG was taken. And on correction of hyperkalemia by the works of GI drip, calcium gluconate, soda bicarb, we could normalize the ECG. The rate also normalized, and the T wave amplitude also came down and became more like normal. So this ECG was actually hyperkalemia. The sinus node dysfunction, the bradycardia also was because of hyperkalemia. But what was most important is that sinus node dysfunction often is not reversible. It's an degeneration of the sinus node. And then we talk in terms of pacemaker. But here, the dysfunction of the sinus node is secondary to hyperkalemia. So identifying reversible causes by having a high index of suspicion, tall peak T waves like this, taller than the R wave, nearing the R wave height, should make you suspect of hyperkalemia. Hyperkalemia patients do have bradycardia. Now, hyperkalemia patients often have a wider QRS also, and the wide QRS here is not seen. So sometimes these atypical features might be there and which might make you work more or think more or investigate more. But yes, the potassium was high, correction of potassium led to normalization of the ECG and the sinus node dysfunction resolved. This is the next question, and here is the ECG, lead 1, 2, 3, AVR, AV, LAVF, B1, 2, 3, 4, 5, 6, and long lead 2. The question to you is, there are these T wave changes. Is it anterior wall ischemia? Is it inferior wall ischemia? Is this pericarditis or is this pulmonary embolism? Your time starts now. All right, so these are the answers which we are seeing. We are seeing that few of them said anterior wall ischemia, few of them thought it's an inferior wall ischemia. Just about 50% thought that this is pulmonary embolism. I think the score is changing. Few people have answered now, and we have more than 50% saying pulmonary embolism. I think this is very important. So this is one of the classic patterns of the ECG which you need to recognize or remember. So let's look. There is sinus tachycardia. There is T wave inversion. T wave inversion is there in the precordial leads V1, V2, V3, up to V4. Even the inferior lead is shown. Importantly, S wave in lead 1, S1. Now we go to lead 3. Q wave in lead 3, T wave inversion in lead 3. S1, Q3, T3 pattern, sinus tachycardia, T wave inversion precordial leads, suggestive of an RV strain pattern. The diagnosis should be pulmonary embolism. So I think this ECG, definitely one should think of pulmonary embolism. Ischemia because of T wave changes are often thought of. Clinical context will definitely be of use, but I must admit that there are situations when in this kind of ECG, people have gone ahead and thought it's ischemia and done a coronary angiogram to find that that's normal, but has a pulmonary embolism. So I think when you have T wave inversions, which happens in, not a fixed territory here, it's inferior and anterior, should raise a doubt whether it's really ischemia or no. And obviously, pericarditis should have a global change in all the leads. All the leads are not showing. And classic S1, Q3, T3 pattern, T wave inversion, sinus tachycardia, all this favor pulmonary embolism. And I think this was the pulmonary embolus which we saw in the pulmonary artery on the echo, 2D echo shot on a short axis. We are seeing a pulmonary thrombus here. All right, moving on to the next question. And next question is again an ECG. And this ECG lead 1 to 3 AVR, AVLF, V1 to V6. And obviously, there is some kind of a gross T wave change which we can see, and maybe hypertrophy. So this ECG, vote for the choices: A, hypertrophic cardiomyopathy; B, it's a hypertensive patient with left ventricular hypertrophy; C, it's an acute coronary syndrome situation with the T wave inversions; or is it aortic stenosis? Your time starts now.
Ten, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Oh, it's a hung parliament, as we would call it. 30% seem to say hypertrophic cardiomyopathy. 35%, 36% say hypertension and left ventricular hypertrophy. Few think that it could be acute coronary syndrome, and some of them also aortic stenosis. I think it's interesting ECG. And again, I would like you to remember the pattern. Remember the pattern. So let's look at this ECG. Now, what we see is T-wave inversion, which are giant, and T-wave inversion are there in the precordial leads. They are there to an extent also in the limb lead, 1, 2, AVF, somewhat in lead 3. So there is T-wave inversion seen everywhere, much more in the precordial leads. Very unlikely this would be an acute coronary syndrome. Then we look at the R wave, and what we see, tall R in V1, V2, V3. There is a R from V1 to V6. So this is definitely suggestive of a hypertrophy pattern. So there is a ventricular hypertrophy. So there is a ventricular hypertrophy and there is a T-wave inversion. So now the question would be, could this be hypertension? Now hypertension and LVH does not present in this manner. You won't get an R in V1. R in V1 would in fact mean that there is a possibility of a biventricular hypertrophy, and hypertension and aortic stenosis, both of them are generally left ventricular hypertrophy. But when you have a R in V1, you should think of a biventricular hypertrophy, and therefore hypertrophic cardiomyopathy is one of the strong possibilities. And that is where, when you have these T-wave inversions, hypertrophic cardiomyopathy, especially the apical variety of hypertrophic cardiomyopathy, can give this giant T-wave inversion. The presence of R in V1, V2 of such nature tells you of a biventricular process, and therefore this is very likely to be hypertrophic cardiomyopathy and giant T-wave inversion of this nature. Now, often it happens that whether it is an acute ischemia, and now if you have a ST depression and T inversion, it's mainly a strain pattern. In acute coronary syndrome, often you will find an ST elevation and then a T-wave inversion. So this is most fitting into a strain pattern. So this is a hypertrophy and strain, and the hypertrophy is because of a hypertrophic cardiomyopathy rather than hypertension or aortic stenosis. Move on to the ECG number 11. I see 125. Ketan, we have time for a couple of ECGs.
Yes, we can take two more.
Two more ECGs. All right. So let's look at this ECG pattern. And your question on this ECG, lead 1 to AVF, V1 to V6. And this is Professor High Valence ECG. I am going to ask you whether this ECG is suggestive of gross STT changes. It's a left main stenosis, It's a proximal LAD stenosis, it's a circumflex stenosis, or it's a non-ST elevation myocardial infarction. Please vote. Timer to be started.
Ten, 9, 8, 7, 6, 5, 4, 3, 2, 1.
All right, let me come to that ECG, and that ECG is here. That ECG is here. So here the question was left main stenosis. Almost 60% have said left main stenosis. Few say it's a non-ST elevation MI. Very few think that it's a proximal LAD stenosis or a circumflex lesion. And I think those who have said that it's a left main stenosis, that is the correct answer. And this is one of the classic ECGs of a critical left main stenosis. And why do we say so? Now, this is because of globality of the ST segment change. When you have an ST segment change in all the 12 leads, as many leads as possible, think of left main stenosis. So if you see in some, you can see vast majority, you can see ST depression, ST elevation here, ST depression, then you have depression here. So 10 out of 12 lead is showing either ST elevation or depression. Majority are showing ST depression. That is correct. And therefore, people saying non-ST elevation MI might be a reasonable thought, but we need to look at the orphan leads. Which are the orphan leads? AVR, not looked at commonly. V1, not looked at commonly. V1 and AVR is showing ST elevation. AVR, the ST elevation is more than V1. And this is classic of a very proximal stenosis of the left coronary artery. So this is a left main stenosis. So very classic of a left main stenosis. ST elevation in V1 and AVR, AVR more than V1 would mean that this is a left main stenosis with T-wave inversion going on from all other precordial leads. So classic left main stenosis. Let me go to the next example here in more or less continuation of the previous ECG. So here there is some story, but let's not look at the story. If we look, there is a T-wave inversion in precordial leads. There is a T-wave inversion. Now, when he complains of angina, the T-wave inversions are not there and T-wave becomes upright. So I'm going to give you both the ECGs and just give you this much of brief that this pattern, recognize this pattern. This pattern of T-wave inversion was when patient has no complaints. T-wave normalization when the patient complains of chest pain like angina. And the question to you is that is this the angina because of left main stenosis? Is it because of proximal LAD stenosis? Is it because of a triple vessel disease? Or is it because of a coronary vasospasm? Please vote. Your time starts now.
Ten, 9, 8, 7, 6, 5, 4, 3, 2, 1.
All right. So I think we were looking at the ECG. This was the question number 12, and this was the ECG asked. So very few said left main stenosis, which is good. Few of them said it's a proximal LAD stenosis, but many thought it's a coronary vasospasm. And then you have some people who say that this could be a triple vessel disease. I think this is a very important ECG, and let's look at this ECG and analyze it very thoroughly. Now, again, in terms of pattern recognition, what I would want to tell you is that if you have this kind of precordial T wave changes in V2, V3, and V4, think of what has been described as a Wellen syndrome or Diswan sign. This strongly favors a critical proximal LAD stenosis, especially when this ECG comes up at rest. See, those patients who have Prince metal angina or coronary vasospasm, at rest their ECG will be normal, and during angina, they will start showing an ST elevation and upright T wave. So that is not there, and therefore this is not a coronary vasospasm which people thought of. Triple vessel disease will also not be of this nature because those who have triple vessel will more or less have a static ECG. ECG will not fluctuate like this. So here the classic ECG is that at rest T wave inversion. With angina, T wave being upright. Classically in V2, V3, V4, this is a critical LAD stenosis in the proximal LAD, and this has also been described as a widowmaker's disease. Identifying this is so important because this patient, if not treated immediately, can land up into a massive anterior wall infarction. This patient needs to go to the cath lab, get an angiogram, and get his LAD fixed. So remember this pattern where at rest you see T wave changes precordially. During angina, you see normalization of the T wave called the Wellen syndrome or Diswan sign. I think, Ketan, I should stop here. And what are the questions or comments which you have? And we could discuss that.
Yeah, can you just stop sharing the slide?
Yes, I will do.
So, yeah, it was a fantastic presentation. Few of the ECGs were really googly. I think it surpassed the current IPL's googly all over there. The way it has gone was fantastic, and the way the background music and all, we were playing that as if the delegates were really playing that Kaun Banega ECG Pati. And we had, for playing this, the quiz master was none other than Mr. Bachchan of electrocardiology, and that was Dr. Amit Vohra himself. So it was really a mind-boggling, and probably the way you put all the patterns, which were so much diagnostic and which was so apt for today's theme, what we were talking about it. This session we had not planned for an interactive because interactive was only for the answering that, and I was so happy that majority of delegates who participated for the voting, and we could have an idea what the delegates are really thinking about. Probably this was way beyond our expectation, which has gone. And friends, I'm sure with your support, this is where we want you all to participate on. We are going to continue our this series of C4, that is Common Cardiology Care for Clinicians. Next weekend being a Diwali holiday, so that's next Sunday is a New Year, so we are not going to have the session. We are going to have our two more sessions with the 22nd November as a theme on hypertension, and 29th November will be a cardiology in pregnancy. At this juncture, I would request all the physicians, those who have not yet become a member of Indian Society of Electrocardiology, please log into the website www.iacindia.org. You can download the registration form and can send it. The official address has been put over there, and you can send along with the documents and the check. And you see that definitely you will feel, if you are really interested in academics and electrocardiology, this is the place where you should not miss out on the opportunity. So I thank so much for all the faculties who had shared their valuable time over here. And at the end, we had definitely the icing on the cake by Dr. Amit Vohra. So thank you so much for that, and for giving the final vote of thanks. May I invite Dr. Samir Muchala, head from Zydus Cadila, to give the vote of thanks. Thank you so much.
Thank you, Dr. Ketan Mehta. I think we had fabulous interactions and deliberations today with respect to diagnostic modalities in cardiology. My heartfelt thanks goes to Dr. Ramesh Dargat for effective moderation of all the three sessions, such that the messages in clinical practice were percolated to our esteemed delegates. The session on ABPM by Dr. Arvind Gongane, Holter monitoring by Dr. Deepak, and EP study by Dr. Ajay Nayak were just apt for the consulting physician so that he can imbibe the maximum from these deliberations and extend the necessary benefit to his ailing patients. As always, Dr. Amit Vora had been fabulous with respect to his ECG strips and having the clinical context and relevance to each of the clinical cases. Last but not the least, congratulations to Dr. Ketan Mehta, Honorary General Secretary of ISC, for coming out with a fabulous agenda and for facilitating today's meeting. I'm happy to share that we had 1,040 delegates from across India who have witnessed today's webinar. My heartfelt thanks to you for sparing your precious time on a Sunday morning, which is actually meant for families, but you have been really active in attending today's webinar. Not only today's webinar, but also supporting our patients during this COVID scare where they really require our support. We will take a break next week. I take this opportunity to wish all of y'all a very happy Diwali and more importantly, a safe and healthy Diwali for the next year. And then we'll meet again on November 22nd, as already alluded by Dr. Ketan Mehta, for another high decibel discussion on hypertension. Thank you very much and have a great day.
Happy Diwali to all of you.
Happy Diwali, Ketan. Happy. Thank
Happy
you.
Diwali.
1,000 is a very good number.
Okay.
Happy Diwali.